Welcome back to the breakout sessions, everyone. This is session 3A. Like the presenters I introduced this morning, our next speakers are also incredibly active on the Medify listserv and have been wonderful mentors in the area of long-acting buprenorphine options, which is what they will be presenting on this afternoon. Kay Dunham is a primary care nurse practitioner with a focus in addiction medicine and a background in emergency medicine. She has been working at the London RAM for over 3 years now, developing microdosing protocols and providing novel, long-lasting buprenorphine treatment options to her patients for over a year. She has been sharing her experience and providing education on these topics across Canada. And Dr. Ken Lee is the medical director at the London RAM Clinic, which was started in 2014 as a part of the Arctic Medify project. This project has developed a care path for patients with addictions from the emergency department to a RAM clinic. Dr. Lee's general medical practice is located with the CMHA, where he provides medical and psychiatric care to persons diagnosed with serious mental illness. He also works as a surgical assistant at London Health Sciences Centre with the Veterans Affairs Canada Operational Stress Injuries Clinic, treating Canadian Forces veterans suffering from PTSD, and with the CPSO as part of the Quality Assurance Committee. Thank you, Katie and Dr. Lee, for being here. I'm really excited for your talk. And just as a reminder to fill out the evaluation forms, and we will be holding questions to the end for a very exciting discussion period. Take it away.
Thank you very much. We started using the long-actings about a year ago, October 2019 for Sublocade and a little bit earlier for Probuphine. And we're going to share our experience with using these two novel delivery systems. Our disclosure slides are next, so we should pop those up and go through some of those.
Okay, so no, that's okay. That was the cue for the slide. That was good. So for our financial disclosures, the program has received no external support for this presentation, but both Dr. Lee and myself have received honorarium from Indivior, specifically for talks on injectable buprenorphine, or brand name Sublocade, and Dr. Lee has as well for the implant, or Probuphine, I believe. Good for the next.
And this is more of the same. So we're going to have a quick look at that, and then we can move on.
So mitigating potential bias, just to go over it quickly. So we will attempt to refer to both the generic and the brand names. I personally am horrible at that, so I'm sorry for whatever comes out of my mouth. We're talking about the injectable buprenorphine, brand name Sublocade, or the implant buprenorphine, brand name Probuphine. We view both depot buprenorphine and implant as additions to and not in replacement of the already well-established evidence-based treatment options available to us. And while we are hoping to increase provider awareness of these novel treatment options, there's no financial gain to either of us for increased uptake in the community. Okay.
So firstly, we'll discuss depot buprenorphine. It's the brand name is Sublocade, and that is the only product that is an injection. Once a patient's been stabilized on a dose of buprenorphine, between 8 and 24 milligrams, they can be offered the depot formulation, Sublocade. It's given every 28 days. You can give the injection 2 days early or up to 2 weeks late. The way the system works is that the buprenorphine is delivered through Atrogel, which is a viscous solution, which is liquid in the syringe. And once you inject it, a chemical reaction occurs and it forms a gel, which sits in the subcutaneous fat and biodegrades over time, releasing a continuous amount of buprenorphine. It does peak in the early days of the injection and then tapers off to over the next 42 days, 28 to 42 days, at which time your next dose is given. It's typically given as 2 300 milligram loading doses, followed by 100 milligram maintenance doses. Okay.
Thanks. So, I mean, I guess we should have said up front, we're really doing the very basics on both of these topics because we did want to focus more on the clinical experience that we have. So if you have more questions about the pharmacodynamics or anything like that that we're going to talk about, feel free to ask them. Otherwise, we're just going to briefly go over it. So to go into that a little bit more, so the goal with buprenorphine, and this is not new information, we've known this for quite a while now, is to have a minimum 70% occupancy at that mu receptor or the opioid receptor to block the subjective drug-liking effects or the opioid blockade of full agonists. That comes from a lot of different research. Some of it, I like the Greenwald papers, like early 2000s, but there's lots of it that's built up to that conclusion. For depot buprenorphine or injectable buprenorphine, Sublocade, we had to find out if with that medication, we're doing at least that goal of achieving minimum 70% occupancy. So they did give patients, actually just 2 patients, different injections. So one received 4 200 milligram Sublocade injections, and the other one received 6 300 milligram injections. And then they did actually a PET scan or a brain scan of these patients, which I think is neat because we don't get that a lot in addiction medicine. And what they found was 75 to 92% occupancy of those mu receptors. So yes, we achieved that goal of minimum 70%, and it was maintained for 28 days, which is very exciting because this is obviously one of the longer lasting treatment options that we have right now, along with probufene, which we'll talk about in a little bit.
So it's all about the plasma concentrations. So this is a Indivior slide from their study showing the effects of a 300 milligram first injection, followed by 100 milligram steady state, which is injections 3, 4, 5, and 6, comparing to a 300 milligram continuous loading dose. So just by way of background, 16 milligrams sublingual buprenorphine gets you a blood plasma level of approximately 2 nanograms per ml. Give or take, depending on patient administration and absorption. So not everyone takes that 16 milligrams exactly the same. So when you look at the column 1 with the first 300 milligram injection, which is the first loading dose, you get an average plasma concentration of 2.19 nanograms per ml. It's not a steady 2.19 with that first dose. The Cmax occurs within the first 3 to 5 days of 5.37 nanograms per ml, dropping to below 2 nanograms per ml, as indicated there, 1.42. So if you're going to get any toxicity reactions, which is the nausea, dizziness, sedation, it's usually only within the first 3 days after that first loading dose that you do experience that. And we have seen that in a minority of patients, maybe about 10% of patients get that opiate toxicity reaction. But 90% of the patients don't get that. And we only see that with the first loading dose of 300. Once patients are on a steady state, which is after, let's say, 4 doses, so it's 300, 300 followed by 100 and 100, your average plasma concentration is 3.21, and you get less of the fluctuations. Compare that to the 300 milligram maintenance dose, where patients are getting continuously 300 milligrams. And by month 4 or 5, their steady state is almost twice as much, not quite twice as much, as the 100 milligram steady state dose. And so there are some clinical situations where you want to choose to use the 300 milligram maintenance. In our practice in London, the 300 milligram maintenance dose typically is used more in the fentanyl users, and for some reason the chronic pain patients who did well on a lower dose sublingually but seem to need a higher 300 milligram maintenance dose. We do try to drop everyone down to the 100 for month 3, and if that's not sufficient, then we bump up to the 300 milligram maintenance. And again, that is in a minority of patients, maybe only 10% as well. Katie.
Background again, that a lot of you, if you're using it, I know a lot of providers are already using this option. You already know this, but there is a Health Canada certification required for both pharmacists and prescribers for the injectable. No patient pickup of this medication, pros and cons to that one. I think mostly pros, because it means the medication goes right from the pharmacist to the clinic where the provider gives that medication. So we know that it's on board at the dose we wanted it to be provided at. It's not given to the patient because it does form that depot or that mass. And some patients, unfortunately, like to inject things. And if they did inject something that formed a mass, that could obviously be catastrophic. It is cold chain requirements, very similar to all of our vaccines, between 2 and 8 degrees Celsius, which is nice for your fridge sake. It does have to be out of the fridge for 15 minutes just to help it get to room temperature before you give the injection. The boxes that are on the screen there, the pink one is the 300 milligrams, if you haven't seen it, and the yellow one is the 100 milligrams. They're pretty much empty. It's a big waste of box, but it does come with the pre-filled syringe, and it does come with a 19 gauge needle. It's a thicker needle, but it is only 5/8. So you would be hard pressed to go into the muscular tissue unless you did have that very thin patient. So most of the time, just like any other sub-Q, you're going to be able to do your 45-degree angle, probably closer to 90 degrees if you have someone that is larger, and probably closer to 20, 30 degrees if you have that thinner patient. Just on that, because I don't think we have a slide on it later, if you do have a really thin patient that you are having a hard time, you really want to make sure you don't hit the muscular tissue. If you do hit muscular tissue, that can cause concerns with ulceration as that mass continues to biodegrade. So for that, we just like to have the patients bear down or try to tense their muscles. And if they do that, you can usually see and definitely feel the muscles tense. And you can grab something sub-Q on top of that. And while you're holding it, you can do the injection into that tissue. It tends to work really, really well. Ken already mentioned you do have to be on 8 to 24 milligrams for 7 days before the injection is the recommendation. We'll talk about obviously some of the off-label applications where we've done it before 7 days. And then he already said as well, the 2 loading doses of 300 milligrams is the recommendation, with 100 milligram maintenance doses after that.
Contraindications, the Atrogel delivery system, which is the delivery system that the buprenorphine is contained in, is contraindicated in pregnancy. Not that it's unsafe in pregnancy. There is a study ongoing, I believe in the US by Indivior, to show that it is safe in pregnancy. I'm not terribly concerned about that, but officially it is contraindicated in pregnancy. So you do want to take some consideration of the pregnancy potential in your female patients. Injection site concerns. There was one question in that came on the chat there about using some local anesthetic before giving the injection. I've been hesitant to do that, and I've never done that because the early reports, there was a case of skin necrosis out of Vancouver, I believe, when Sublocade was on the Health Canada Special Access Program, where they did use local anesthetic, and they did get some skin site breakdown after using some lidocaine in the area of the injection. So I've been hesitant to do that. Basically, what we do is offer a really, really good ice pack. So instead of freezing with lidocaine, we freeze with ice. Not really freeze it, just cool it down, and then reapply the ice pack immediately after you do your injection. So the burning pain that you get from injecting Sublocade doesn't start until about the 10-second mark. We were taught to initially inject it slowly, but it seemed like a painful torture to do it that way. So we switched very early on to injecting it quickly. And we can do 100 milligram injection basically almost before the burning starts. With the 300 milligram injection, which is 1.5 cc's, you can't get it in fast enough to before the burning starts. So that's, in those situations, the ice pack helps. And essentially, it is the skinnier patients that complain more of the burning sensation. And sadly, I'll have to report that it's men that complain more than women. The usual side effects with buprenorphine, constipation is probably the most common. Manage that with the same ways you would have managed constipation with sublingual buprenorphine. Liver enzymes are a concern. It is in the product monograph to monitor liver enzymes in both buprenorphine, Suboxone, and with Sublocade. And we did have one case of a patient with significantly elevated liver enzymes where we did choose to discontinue Sublocade, but that may have been due to other factors. We don't routinely check liver enzymes. We do check them on intake for patients who agree to have blood work done. But we don't necessarily monitor the liver enzymes unless there's another reason to monitor liver enzymes, whether it's comorbid alcohol use disorder or hepatitis C or some other reason, NASH, fatty liver, etc. We may want to monitor those patients a little more carefully with regards to liver enzymes. Okay.
Yep. Just to touch on the constipation, I don't know about you, Ken, but I've only had one patient with Sublocade complain of it, honestly, so far. And that patient had the issue on the 300 milligrams that was resolved going down to the 100 milligrams. So just like you said, it hasn't been that big of a deal, more than buprenorphine sublingual anyways.
Yeah. Peg Light is one of my favorites for managing that.
Sorry, what'd you say?
Peg Light is one of my favorites for managing constipation.
Agreed. And then I just saw the question pop up too for pregnancy. It's kind of nice that we're co-presenting because then you can read some of the chat. For the question about how you do your talk about pregnancy when someone, if they did become pregnant. First of all, I did develop a consent form that's just been developed from the monograph, honestly, in Health Canada's special access form that we have just for our clinic that I try to have patients sign beforehand that goes through all the risks and benefits, remembering that these are patients that have already been on buprenorphine sublingual. So most of the contraindications for these patients don't exist because they're already on buprenorphine itself. But I do highlight the risk in case of pregnancy, the kind of theoretical risk at this point so that they're aware of it. There was a paper that was put out with 3 case studies about pregnancy. 2, maybe I made that up, maybe it's only 2 case studies, but it is an interesting read. For both of those patients, the patient chose to discontinue Sublocade after each was a different number of injections when they found out that they were pregnant, and they actually chose not to continue with any therapy throughout their pregnancy, which I'm guessing was not their provider's recommendation. But because the medication is so long lasting, neither of those pregnancies had complication, and neither of those patients had withdrawal symptoms throughout the pregnancy, and the infants had no concerns either, which is pretty exciting news. So if it did come, and there's a case that is not my case that I had to walk someone else through, love you provider out there, a pregnancy that did happen on Sublocade as well. It's just a conversation about the potential risks and benefits, I think. And like Ken was alluding to, I think, the biggest risk during pregnancy is facing withdrawal symptoms. And because there are such high concentrations of buprenorphine with the injectable, any switch of medication could contribute to withdrawal symptoms. So just being cautious about that, depending on how far along that pregnancy is. I warned Monique I talk a lot, so I'll go to the next slide, sorry. So, sorry, this is just to go over more of the case studies that we have instead of talking about the background of it. So when do we use Sublocade in our practice? One, and I think the obvious one for a lot of people, is the high-risk patients. So these are patients that have high-risk lifestyles. Maybe they don't have somewhere to stay consistently or somewhere safe to stay. In and out of shelters, a lot are on the street. High risk of infections, lots of hospitalizations, and high risk for overdose, probably with a lot of overdoses in the past. So just 2 case examples for this, I guess. One main one is a 50-something-year-old female that we have who prefers injection fentanyl, but she'll use anything, has been using her whole life. She's been in our program for a long time, but is constantly restarting and was coming to the clinic with numbers of missed doses and having to restart again. Admits that if she had the choice to use something else, she would stop her Suboxone so that she could enjoy using something else. So that happened a lot. And last year alone, she had over 5 hospitalizations with infections related to injection use, one of them with a brain abscess and staying in the hospital for months. And she was in between shelters most of the time. So because she's so high risk, we did apply to Health Canada for special access to get her Sublocade before it was to market. And thank goodness we did, because she has received the injection now that she's been on it. I don't even know what number she's on, 11, 12 for the injection, but every single 28 days, I think she was maybe 1 week late once, she's been into the clinic to get the injection, which is a miracle on its own, that she has been so consistent with coming to get the injection. She has 0 hospitalizations since she started the injection. She actually has been opioid free for quite a few months now, which is really exciting. She's still using stimulants, but we're working on that. And she's been in the same and stable housing the entire time, to the point that she has a little bit more money now. And she's actually gaining some weight because she's able to get, access to foods now that she wasn't able to before. So she will admit herself that this really has been life-changing for her and a huge success story. Bonuses that I put there on the side for high-risk patients: provider administered, so you don't have to worry about them going to get it or not from the pharmacy. Increased compliance, obviously, because you gave it to them. Constant steady state of the medication, when a lot of our patients will complain about peaks and troughs of sublingual. No missed doses. We'll talk about, what happens if you miss that 42-day window afterwards. No restarts as long as you come in again in that window. And then I just starred overdose protection. So I'll give one story, and Ken will probably give another one afterwards, because this is just our case stories. These are anecdotal stories so far, but we do have a youth patient that is on Sublocade as well. Received 4 injections, so 300, 300, 100, 100, and then discontinued, and she relapsed. She came back to our clinic 2 months after her relapse, or I guess into her relapse. And the reason she came back is the week before she was injecting fentanyl with a friend, and her friend unfortunately overdosed, whereas our patient, using the same fentanyl, who knows how much, but did not overdose, reports no respiratory concerns at all. In fact, wasn't even able to get that euphoric effect that she was looking for. So in that moment, she knew that she had to come back into the clinic, and we restarted her back onto sublingual and then put her right back onto Sublocade. So that's just one of the stories. For the stable patients, and this could be any number of the patients. Sorry, Ken, did you have something to add?
In terms of how much overdose protection you get, the patients report to us they can use 4 to 5 points of fentanyl IV or smoking, snorting, whatever, and they get very little euphoric effect from it. You can overdose on Sublocade. So we did have one patient who decided to try to override the Sublocade by using 10 points of fentanyl, and yes, he was successful in achieving a high, and did actually overdose, requiring a reversal with naloxone.
Ken, can you speak up a little bit? They're just asking.
Sure. We did have one patient who did overdose while on Sublocade using about 10 points of fentanyl, but we're pretty sure that by patient reports that about 4 or 5 points of fentanyl will be blocked out by Sublocade.
Yeah. That particular patient says that he was using, had just injected 3 points before the overdose, but he uses, like Ken said, 1 gram to 1.5 grams a day. So he's a significant user, and who knows how much he'd had on board before that injection. So luckily we do know now that naloxone will bring you back, which is good to have. And that patient's a little bit of a different story altogether. So for the stable patients, again, obvious benefits, I think, to why they would want a long-lasting medication. So this is for a working patient that just has too many other commitments, care providers, whether it's for their children or their parents or anyone else, and people that have to travel a lot for work or pleasure. So for this, it's obvious less clinic visits for a lot of patients, less to no pharmacy visits required for many people, no observed dosing, which means no take-home medications and no safe storage at home. So we do have, again, quite a few huge success stories that are in the stable patient category. One that I think is worth telling is a patient who I actually microdosed onto buprenorphine sublingual last year. And I thought she was doing great. She showed up all the time. She did fantastic. She loved our clinic. She loved us, no problems. She'd stopped using opioids. And then we offered her the injectable, and so she switched over to it. And honestly, from that 28-day point when she came back in to see us first after her first injection on, every single time she comes in, she's almost in tears telling us how grateful she is for this injection, because the overwhelming sense of freedom that she got when she first left our clinic was so powerful for her. This was the first time in her life since she was a little kid that she didn't take something by mouth every single day. And that was so freeing for her. And it really was what was required to break that pill to mouth cycle, which kind of leads me into tapering, which is the next one. So you can use the injectable for tapering as well. So after 4 to 6 months of regular injections, when you are hitting that steady state, you can actually have buprenorphine in your system for up to 12 months afterwards. So it's a very long-lasting medication. And that makes it really great for a nice, slow, easy taper off of the medication, because we know a lot of patients struggle to decrease their sublingual doses. So I kind of see it as, for some patients, the next step in recovery for them. And this is the patient that constantly comes in and says, you know, I'm ready to taper. I'm so ready to taper. I want to taper. And they may be saying this from day one before they're even off of opioids, but they're telling you this. So for them, I would say, let's try Sublocade or the injectable. Let's give it a chance. And if you can do well on this, if you can break that pill to mouth cycle, then possibly we could consider a taper off of that. Some people have been saying they use the injectable for a quick taper, and there is a case study on that as well, where they did give patients that were on less than 8 milligrams a 100 milligram injection to taper, and that seemed to work well. But I actually like to offer it as a taper because it buys me, if I tell them I need them to get 4 to 6 injections before I consider tapering, it buys me them in my program for another 4 to 6 months, where they have the counseling and they're coming to see us and we can check and see how they're doing afterwards. Okay, again, I'm talking a lot. I'll let you go, Ken, sorry.
Case studies, not as successful. So there was a question here about chronic pain patients. Even though you're sublingual, you can have a chronic pain patient who has developed behaviors that are more OUD-like, and they're getting 24 milligrams of Suboxone and seem to be doing well. Occasionally, you will convert the patient. Well, we have tried converting some of these patients to Sublocade 300. Some of them don't do well at Sublocade when we drop it down to 100 milligrams, and we go back to 300 milligrams. But you know, for a certain subgroup of patients in this chronic pain population, even though you get almost double, sometimes triple the dose, the blood plasma levels of buprenorphine with Sublocade 300, they still don't seem to do quite as well. Now, not every chronic pain patient is like this, but I would say a good 50% of them still complain that their pain control is not as good as compared to taking oral medication. Doesn't quite make sense pharmacologically, but that's what we're observing. Microdose conversions. We have converted patients from their fentanyl use or methadone via buprenorphine microdosing, and then quickly converted to Sublocade. And that has worked generally fairly well. We're a little more conservative with methadone conversions. We do want to see that the methadone EDDP is negative before we convert, and that's just for our comfort level. In some of the patients who are fentanyl users and heavy fentanyl users, we have done microdose conversions and a fairly quick conversion to Sublocade to give them some overdose protection. And in some of those patients, we've elected to go with a 100 milligram starting dose because of some toxicity reactions that happen with the 300 milligram loading dose, particularly in patients that continue to use fentanyl when you do the Sublocade conversion. So it is mitigated somewhat with a 100 milligram starting dose. They do get some withdrawal symptoms at the end of the month, and you may need to supplement. But then we'll go to the 300 milligram doses for numbers 2 and 3 just to get the plasma levels up higher to steady state as in the usual fashion. And fentanyl, again, we're very scared of fentanyl. We're very wary of fentanyl, and Suboxone, buprenorphine may not be the best option for your fentanyl users. It may be that they should do better on methadone. That's a discussion that was this morning with Mel Cahan. Anything to add on that, Katie?
No, I think that was good. I think it's just for me anyways, I don't recommend doing the 100 milligram starts, just because those have been the ones where we did end up with patients that had significant withdrawal symptoms starting only 2 weeks after their injection. So if you did want to do 100 milligram start, you would have to expect that you're going to top up with sublingual on top of that. But because our patients did have so much withdrawal, in the one case I can think of where we did do this, they ended up using a lot more fentanyl that month and didn't increase their use significantly. So then when we did go to give the 300 milligram injection at the 28-day mark, and counseling saying it's going to be fine, no worries, because we already have Sublocade on board, it didn't go well. They ended up with significant precipitated withdrawal because they had been using so much fentanyl, and because I don't know what their buprenorphine concentration was at that point, because they'd only had 100 milligrams over 28 days ago. So no matter what, I would say if you can go for the 300 milligram starting doses, I think it's worthwhile. But I know we're taking up all the time, I'm sorry. So we'll head on to Probuphine. Sorry, Ken.
Probuphine is the, are you talking? Oh, you go ahead.
Probuphine is the implant. I'm sorry, there's a lot of questions, so I don't know if you would prefer to go to those. You can just put in the chat. But this is the 4 rods of Probuphine, 80 milligrams each. They're 26 millimeters, pretty tiny. We have a picture on the next slide. They go into the upper arm, just in this area here, in between the bicep and tricep, in that groove. It is a procedure, so you do have to be trained to do it beforehand, but honestly, it's pretty simple procedure on buprenorphine doses of 8 milligrams or less, and approved for cycles, so arm. Remove the rods in the other arm. Honestly, most of our patients, other than literally one so far, have chosen this option to help them with a taper. And we have our longest patient so far over a year with the first set of rods in place and still coming up buprenorphine positive that we just checked last month. So it is very, very long lasting and no withdrawal symptoms.
The implant procedure is fairly simple, as Katie indicated. You do use local anesthetic, just steri strips to close. You don't need any sutures. The implant procedure takes about 15 minutes. It may be an additional 5-10 minutes beforehand to just set up your trays. But once you get good at it, you can do the whole procedure within 15 minutes or so. The explant procedure takes a little bit longer. It takes about 30 minutes. You need to use a little more local anesthetic and suggest using xylocaine with epinephrine because it cuts down on the bleeding. And then you do need to put in probably about 3 or 4 sutures to close the area. There can be some difficulty if a rod is deeper than it should be, and that may take a little bit extra time to get that implant out. For a terminal taper, that is someone who wants to come off of buprenorphine. It takes about 5 months, maybe 6 months for the UDS to be buprenorphine negative, and at that time you can choose to remove the rods electively. There's no urgency in removing the rods, and there they are, 26 millimeters long, just about an inch long, and there's the insertion trocar for putting it in, and that is that's a patient with the rods in situ, and that's the injection. That's the sites where you're going to remove the rods, so some midway up from the implant site, and that's the shape of the 4 implants in the upper arm.
I'm sorry we talked so much. We'll try to answer as many questions as we can quickly, but thank you guys for listening. Sorry, I talked so much.
You did good. Last slide.
Already, so maybe we'll start with Lindsay's question. She asked, what happens if the patient is more than 2 weeks late for their injection? Do they have to do a reinitiation protocol?
I'll go for that question. You don't have to do a reinitiation protocol. What you should do is perhaps restabilize them on an oral dose of buprenorphine for about 7 days. And if you can establish a stable dose of 8 milligrams or more, then you can simply go ahead and continue with your 100 milligram maintenance dose. If it goes beyond perhaps 4 weeks, 6 weeks, then you may need to stabilize at a slightly higher dose, and then at that point in time, if it's beyond a month, you might want to consider using another 300 milligram load. And then following that, you can make a decision whether you're going to give a second 300 milligram load or just go back to the 100. I'd be inclined to say that if they're very comfortable after that first 300 restart dose, then you'd be okay going to the 100 maintenance dose at that point in time.
Okay, thank you, Ken. Very helpful. Marilyn's wondering, would there be any risk in using it with geriatric patients? And I think she's referring to Sublocade.
Do we have any patients on it over 65? We have a patient close to 65, but I don't know if anybody's over 65.
I'm not
I
sure.
don't have any particular concerns about using Sublocade in an older population. I would just look at their other comorbidities and decide whether you want someone. Keep in mind that it's a significantly higher plasma level with Sublocade versus sublingual.
Great. I'll skip my own question because I can ask you later, but Karina's asking, what is your policy regarding missed doses of Suboxone prior to getting Sublocade?
Sure. I'll take this one. We don't have a policy per se, but I wouldn't think that they would be that important. Buprenorphine being so long lasting, as long as the patient has established that they're going to be over 8 milligrams in the end, somewhere between 8 to 24 milligrams. And as long as you've established that they're not going to go into precipitated withdrawal, then I would feel fine about going ahead and giving the first injection. Only addendum to that would be fentanyl use. If they're using a lot of fentanyl, I would try to get as much Suboxone into them before you give the injection, even if that's kind of what Ken said, and doing a really big dose of Suboxone before you give the injection just to test and make sure there won't be any precipitated.
Wonderful, so helpful. And maybe just final question before we wrap up. Who is the contact to get the Health Canada training required to offer Sublocade?
That would be your local Indivior rep would have that information. And the training is so simple. It's basically an online training followed by 10 questions that you could never get wrong. So it is pretty simple.
Yeah.
Great. Thank you both so much. Such an informative talk. I know I learned a lot, and I'm sure you're going to get plenty of emails as well afterwards. I know there's a few questions still lingering. So with that, I will adjourn the session, but I really appreciate your contribution. Thank you so much.
Thanks, guys. Sorry we didn't get to answer everyone's question. Thank you. Thanks, Monique.
Yeah.